Our symposium will be on the dry eye, the importance of the ocular surface in sports vision, something that I think has been overlooked in the past, and hopefully after the next 45 minutes to an hour will be crystal clear. Presented by Christen Kenrick and Alan Schlussel.
Great. Thank you so much. We're both really excited to be here, and one of the things that I think we both found when we were doing a little research for this is this really is an emerging field. We all think dry eye, and you think those little ladies that come in and the red eyes, and what about looking at the ocular surface and tear film in athletes?
Yeah, I also agree. I mean, when we're given this task, I said to myself, and when I spoke to Christen, is, how would this really impact people doing sports vision? But now that we've done the research and all the hours we spent on the lecture, there is actually a big implication, and I guess an implication for future research to look at blink rate and things like that. I want to thank you for having us. I'm a local SUNY graduate, so it's kind of exciting to be back here. We weren't at this school, we were on 24th Street, but it's great to be back.
And I've never been here before, but I'm impressed. I'm up in Boston, but I'm originally from Indiana. Okay, so we have limited time and a lot of stuff to cover. We're going to talk a little about the optics of the ocular surface, the basic anatomy, just to refresh that in everybody's mind so we're all on the same page. A little bit about environmental effects on the ocular surface as well as contact lens wear, and then looking at diagnosis and management, not so much that typical dry eye diagnosis and management, but what about in our athletes? All right, so Alan's going to start us off.
Okay, so on the optics of the ocular surface, something we know, and most of us probably didn't know specifically, but the air-tear film interface contributes about 70% of the vergence of the eyes. So certainly any kind of disruption of the ocular surface could impact on visual performance. Certainly some of the variations in the shape of the cornea can develop from the tear film, any disruption of blink rate, incomplete blinks, any kind of poor quality tear film. Certainly as we get into evaporative dry eye, we know about the lack of the evaporation of tear film, what that impacts. And studies have shown that it does impact on the performance in performance of the tear film and certainly optical acuity of what we're seeing. Changes in this tear film have definitely shown disruption during the blink rate, and that smooth optical surface that we're used to having, clean, pristine cornea, breaks down after about 3-4 seconds. And some of the research I noticed said that after about 3 seconds, you get a lowering of the contrast sensitivity and increase in high order aberrations. And you have to I'm not sure, we were just talking during the break, whether any research has been done on athletes on what their blink rate is. It'd be interesting to see for a baseball player, when the pitch is coming, are they holding back the blink like a computer user is? So I think when we've done the research, we see that a computer user and a baseball player might have very similarities in terms of the tear film. They're staring. Certainly in the baseball player, you got the environment in role in terms of the pollution, the dirt, tennis players. Things like that can certainly impact the tear film. And they've also done some research on the breakup time over a soft contact lens and how that introduces refractive aberrations. And certainly we know in patients that wear contacts, they're more aware of dryness. They complain more of dryness than the average population. And we'll talk about a little bit later about different types of materials that might be better for those patients. Chris is now going to talk about the anatomy of the tear film and the anatomy of the ocular surface.
Okay, and this is just a brief review, so we're all starting on the same page. As we know, we've got the outer lipid layer, and then the aqueous phase, and then the glycocalyx layer, or the mucin layer, and then the corneal surface. However, these aren't distinct layers. There's intermingling and mixing of these components. Working the other direction, starting with the corneal epithelium and the microvilli. I just put this picture in here because it's incredibly cool that they've imaged individual microvilli. Now, the goal of all of this is don't let the tear film evaporate to the point where you've got exposure of the microvilli. Not only does that not feel very good, but that's really going to degrade the acuity as well. The goblet cells produce mucin. There's lots of different types of mucin, and it acts not only as a base of the tear film and kind of adhering things together, but also there are some intracellular signaling pathways in that. And this is certainly, you could spend hours on each segment of the tear layer, the tear film, and talking about how that affects vision. But what we want to primarily focus on is both the aqueous phase and then the lipid phase. So the aqueous phase we're all familiar with. It is secreted by the lacrimal glands, main, palpebral, and accessory, and then drains through the canaliculi. But it's the meibomian glands that are near and dear, at least to my heart. They are modified sebaceous glands, and you have 25 to 40 in the upper lid, 20 to 30 in the lower lid. It's a central duct surrounded by 15 to 30 individual acini. And the meibum that comes out of there, classically think of that as, great, there's some oil coming out, layer of oil will stop the water from evaporating, but there's actually over 1,000 molecular species in that meibum. And these are just a few images from transilluminated infrared meibography where you can see those actual individual acini. Okay, so let's talk a little bit about environmental effects and what this does to the ocular surface. One of the big things in the dry eye world is talking about LIMP's study that showed 86% of all dry eye is evaporative dry eye. This is so important that we put it on a slide all by itself. Really, when you're thinking about the ocular surface, in patients who are symptomatic and complain of dry eye, it's really about evaporation and lack of that lipid layer. And that's going to be true of even patients who are maybe subsymptomatic, and especially with the sports population, the athletes, hopefully we're intervening before they come to you complaining of significant symptoms. So the basis of evaporative dry eye is there's obstruction and stasis of the meibomian glands, which decreases the lipid secretions. That means that there's a decreased lipid layer thickness on the tear film. Evaporation of the aqueous layer increases, so the aqueous is thinned, and that's where you get the unstable tear film and poor stability. So anything that causes evaporative stress will contribute to this. There was a great study out of Jester's lab looking at the effect of dry, low humidity environments on mice, and actually dissecting and doing the pathology of the glands, and just putting a mouse in a low humidity drafty environment causes morphological changes, depletes the stem cells, early aging, gland atrophy, dropout. All of this happens just from being in a low humidity environment. So what if we're in another environment where we've increased evaporative stress? So decreasing blink, wearing contact lenses, any of those sorts of things. There can be profound implications from that. Okay, and I'm going to turn it back over to Alan to talk a little bit about contact lens wear.
Well, one of the things we talk about in dry eyes is patients with contact lens discomfort. What is the discomfort? Where is it coming from? What factors affect comfort in contacts? And we certainly know a compromised tear film will have a profound impact on the dynamic acuity, and certainly sports where there are quick saccadic eye movements, it's going to be affected even more. So we're looking for contact. Over the years, contact materials have gotten much better, and they're more wettable, they're more lubricious, they have a lower modulus, and that seems to be helping a lot of our patients. So the factors we think are really important are the tear film, of course, the meibomian glands, the health of the meibomian glands. As Chris was saying, we need to intervene much sooner in the cycle, and we don't want to wait to the point where it's obviously you can see them across the room that they have meibomian gland dysfunction. You want to get them at the point where they're starting to get some stasis of the glands, and you're not getting good production of the oil. Blinking is hugely important. Christen is going to definitely look into that and talk about blink exercises, incomplete blinks. I was just looking at, before we did the talk, on people that use computers and people that use digital devices, and many of them have low blink rates, and you also have incomplete blinks. So if you get an incomplete blink, what are you doing to the bottom of the tear film as the tear comes across? You're certainly getting more desiccation on the patients with severe dry eye, but you're certainly probably getting more high-order aberrations in the lower part of the tear film, and it would be interesting to see research. What we can get from that is what effect on performance it's having. So we're going to talk a little bit today about, can we increase the tear quality and what effect that might have on tear performance. Evaporation certainly goes hand in hand, and we look at the lubricity of the topical cornea and the sclera. People with pinguecula, we know that for a fact that they have much drier eyes, they have problems wearing contacts. they don't have a very lubricious surface. The edge of the contact is hitting the pinguecula, causing disruption. You're getting tear breakdown, and you're getting a lot of desiccation alongside the pinguecula. Those patients are challenges to fit contacts that we all had. Many of those patients, especially if they're athletes, might have a benefit to having them removed or possibly put them on a medication or some type of meibomian gland improvement to try to get better tear flow. And possibly giving them advice when they wear contacts, what should they do before a game? And should they be looking at their cell phone on the bus going to the game and not blinking very much, or should they change contacts in the middle of a game? I've had experience with just patients in my practice. I just tell them when you're at a break, just take your contacts out, soak them, or replace a daily and put a new one in. Maybe that could help in athletes, before they are in a game or in between innings or a hockey goalie in between periods. Certainly that might help them. Athletes in contacts, what should we fit, why, and what benefits of different materials over others? Certainly we know that the manufacturers spent a lot of time and money in marketing the different improved comfort. The silicone hydrogels are much better than they were 30 years ago when I started practice. They're now very wettable. They're daily replacement. We do feel that the surface properties and the wettability of materials are much better than they used to be. And going forward, I think they'll be even better. Certainly there'll be new materials, dailies that have some type of wetting agent within the lens, maybe a medical wetting agent that'll help. And I think that'll help with our evaporative dry eye patients. But there have been different types of treatments. Every manufacturer has their own proprietary either surface treatment or within the matrix of the lens or something that leaches out during the course of the day that helps the wettability. And they've done a good job, and certainly the dailies now are much available in a variety of prescriptions. We have, silicone dailies in toric designs. We have multifocal. We have almost any imaginable prescription except for the custom prescriptions. So as kind of a summary, daily disposables definitely decrease the amount of allergens. People with allergies, people in a poor environment like baseball players, I guess tennis players would be a good solution. They definitely have more allergies, and replacing the lens more often definitely helps the wettability of the material and should help with their visual performance. Then you have patients that aren't candidates for dailies. You have people with high cylindrical prescriptions. You have people with maybe poor quality of they have aberrations within the topography. Those patients might do better with a scleral design. A lot of research has been done on sclerals and dry eyes, and I think that would be an implication for athletes. And even the hybrid lenses, I've had pretty good experience with some of the athletes, just helping them. They're not the most comfortable, but within a few innings or a few innings of a game, they definitely get decent comfort. And now they're made of a silicone skirt, so they work much better for that. Some studies that have been done on the environmental effects of the tear film and how it applies to contact lens wearers. Maruyama did a study in 2004 and looked at ambient temperature and relative humidity and noticed that the tear film on the contact became much thinner and the breakup time became shorter as dryness increased. So there's definitely something there when it comes to wearing contacts and the effect of the contact lens and the dry eye in terms of their visual performance and the quality of their vision. The dryness is certainly more pronounced in people that wear contacts with a high water content, and I think that's something we taught in optometry school, go with a low water content lens for a person with a poor quantity of tears. But I think now we're looking at, for different materials, a lot of the silicone hydrogels do have a low water content, but they have a very high decay. So we definitely want to recommend the low water content contacts for individuals who play sports, especially those in the low temperature and humidity. There'll be a study that comes up right after this that talks about low temperature, low humidity, and how that their tear breakup time and things like that are affected. We can also extend this to non-athletes during winter months or even athletes during winter months. Certainly playing ice hockey outside or even on a hockey rink, you're certainly stimulating a very cold temperature, obviously, in a very low humidity environment. And you do get more dryness and more complaints. So I think we can extend this to improving the quality of the tears, might help their performance, and then I guess research will say in the future whether that really pans out. We're going to go over a little bit of diagnosis of tear film in athletes. This particular study was interesting because Quevedo did a study on elite athletes and looked at the tear film of this group of elite athletes and compared them with sedentary patients, just sedentary population, and also looked at what the effects of training was on the tear film. And when compensation was made of the irregular corneal surface is not made by the tear film, you get breakup time, you get poor quality of image. The larger image is required to perceive the nature of the object. So they had a little bit more time to analyze the image. And obviously this affected the loss of detail and loss of time, which obviously is a very critical factor in athletic events, is you want to get quick detail and quick resolution of the image for a baseball player or hockey player. Some of the conclusions that we looked at is that the baseline tear film characteristics of a group of elite athletes did not differ from the sedentary group, but the quality and the quantity of the tear film decreased after training. So a lot of athletic training did seem to decrease the quality and the quantity of the tear film. So maybe something to be said for an athlete, maybe not work out right before an event. Maybe just take it easy and listen to their songs on their phone and maybe just veg out for a couple an hour before the game and not just do heavy exercise, because dehydration, I think, is an effect. We know some studies on dehydration. That affects the tear film and tear performance. So I think there's something to be said for that. And this study was done a long time ago, over 10 years ago. He looked at pentathlon athletes and how they suffer the most dramatic changes in the tear film after shooting. That's interesting because I guess they're staring, and that's similar to the other athletes. They're staring at their target and they're not blinking, and the lack of blink cycle, the lowering the blink cycle, I'm sure it does affect their quality of vision and the blink rate. Tennis players also suffered a significant alteration. The suspicion of the clavata was due to evaporation, and it's probably true, is that they're aqueous and they don't have much of the lipid function that's protecting the tear film from breaking down. And certainly tennis players play outside a lot. You know, if they're not playing competitively, they play on a grass court. They don't play in grass courts very much, but clay courts, and you get a lot of dust. And we know dust is certainly a factor in tear performance and tear quality. We're going to go over a little bit about the testing of MGD. MGD, as we discussed, is the overwhelming factor in dry eye or ocular surface disease. In our practice, 90% of patients come in with some type of symptom: red eyes, my eyes feel tired. And one overlooked symptom we have in dry eyes is blurred vision. I think people will assess that my vision is blurred, and they think it's a prescription change. They think it's a contact change, and probably half the time it's not a prescription or X change. They're seeing fine in their prescription, but their tear quality is lousy. They're not blinking completely. They're getting disruption of their tears. They're getting a lot of redness, hyperemia, swelling, and that's what they perceive as a change in prescription, when in fact it's actually, if you improve their tear performance by a better quality lens, going from a monthly to a daily, going to a different disinfection system for maybe a monthly or yearly lens if it's a hard lens, that helps their tear performance. And we're also even just wetting the lenses with a lipid drop. So one of the things that really makes it simple to pick out a meibomian gland or the tear film problem is really the symptomatic questionnaires. The SPEED, the OSDI are great to just give to the patient in the waiting room. Or if you have a patient that you might suspect dry eyes, you give them the questionnaire. It takes them about 5 minutes. They have an iPad app on the OSDI, and they grade it, and it really gives you a number, and patients like a number. They like to refer to a number compared to the average person, and they want to then, when they come back after you've improved their tear quality or give them treatment, or in the case of an athlete, they want to see how has this improved. So they come back in a month or two, and they have been on cyclosporin, they've been on a steroid drop, and see if their questionnaire, the improvements are very avid. They do see the difference. We see the difference in just the questionnaires. So that's a quick, down and dirty way to just assess tear film without even looking under the microscope. You also want to look at the meibum secretions. You want to squeeze the glands, the lower gland. You want to see if there's even flow of, with very little pressure, you want to see if there's an even flow of oil coming out of the tear glands. If there's any kind of stasis and you see any kind of, those tear margins look irregular, they look reddened, there's a lot of blood vessels, hyperemia, those patients have long-standing meibomian gland dysfunction. But in this case of athletes, young athletes, probably many of them have fine tear glands. They're just not blinking properly, they're not keeping their contacts moist, or if they're post-LASIK, they probably have a compromised tear film also. Tear osmolarity has been a big thing. Also, we're looking at the number they get. You can refer to a number before treatment, after treatment, and see. And it does correlate with dry eye. I think osmolarity is more in line with aqueous function, but I think you can also see it in any dry measure of the layer thickness. So you can't really do that easily with a microscope, but there are some more sophisticated devices. There's certainly topographers that can measure that. That can look at the quality of the lipid layer thickness and can measure that to really accurate numbers. And you can use that for before and after. You can use that for diagnosis. And the last one is obvious, something we've learned in optometry school, tear breakup time. I mean, that's something we've been touching upon, and that's pretty obvious.
Okay, so I see a lot of people, or I see a few people protecting their ocular surface by lowering their eyes. So we're going to do a little audience participation about what Alan was talking about, that one of the frequently overlooked symptoms here is blur or visual changes. So everybody, I want you to do this. I want you to blink 1, blink 2, blink 3, and now don't blink 1, don't blink 2, don't blink 3, don't blink 4, don't blink 5, don't blink 6, don't blink 7, don't blink 8, don't blink 9. And I think I've seen most people blink by now. But you can see, yes, there's the burning or the sensation, like I want to blink, but you can also see what happens to your vision when you're doing that. Your vision changes quality. Now, I don't know if you can tell by looking at me, I'm not an athlete by any way, shape, or form, but if I had, a baseball or a hockey puck or a football guy or anybody coming at me, my instinct is, let's not blink. I don't want to miss this, because if the ball's traveling 90 miles an hour-ish, you blink, you're going to miss it. So how do we balance those two things? How do we balance blinking, that visual engagement period that our speakers mentioned this morning, that attention time, that quiet eye time, versus, well, I've got to protect my ocular surface, because if I have an open eye, my vision is going to decrease over time. So let's talk a little about the ocular surface. So you see these people in However, the athlete, especially when we're talking about elite athletes, you're going to have more of this normal appearance. You've got a nice white, quiet eye. That lower lid is even. The lashes are clean, and you think, I don't have to worry about dry eye here. This is fine. So the next thing is, well, what happens when this person blinks throughout the day? So we have the pressure exerted with a deliberate blink is about 1.25 millimeters squared. And so this technique using a meibomian gland evaluator mimics that force. So it's putting a very gentle force on the meibomian glands, similar to what you would see from a deliberate blink. And we want to see what comes out of the meibomian glands. Well, in this case, nothing. So right there, you already have a bit of a problem. Now, the forceful expression all the way over to the right, still nothing coming out of these glands. So that's a problem, because you don't have athletes standing there squeezing their lids trying to get meibum out to protect the tear layer. So we need to look at this, even though the patient may not be symptomatic, even though we may look at the slit lamp and say, it's a white and quiet eye, let's spend our time elsewhere. So looking at meibomian gland dysfunction, just like anything else, the diagnosis is made based on structure and function, the same way that you diagnose glaucoma or any other ocular condition. The function of the glands requires some sort of expression, physical expression, because we want to know, how do these work? Ideally, what comes out should be clear, and there should be a fair amount of it, and it should be this nice sort of olive oil consistency. If, when you express the glands, you get the gross stuff on the bottom, that's not the best quality. Not only does that not provide the smooth refractive surface to prevent the aqueous evaporation, but you also get particles in the tear film, and anytime you have particles in the tear film, whether it's globs of this oil, whether it's dust or environmental debris, that's going to refract light differently. It's going to scatter light and ultimately degrade your optical image. what I recommend using is the meibomian gland evaluator. This is a standardized amount of 1.25 grams per millimeter squared, which is the same as a deliberate blink. The main reason I recommend doing this is because I can't help myself. If I have my finger next to a gland and I start to see a little stuff come out, I push harder and harder and harder, and it's like so satisfying to get those glands to open up. This makes me stop. It makes me stay at that deliberate amount of pressure that's more indicative of day-to-day performance. Then looking at structure. So you can do this either, these images may be a little better if they're darker, but essentially those top ones are just a transilluminator, something we all have in our office, everting the lower lid. Ooh, thank you so much. Everting the lower lid and looking at the gland structure. When you start to see truncation of the glands, or when you see very dilated, you know there are changes happening at the physiologic level. And so even if you don't have symptoms, if the ocular surface looks white and quiet, that's the beginning of the cascade. These lower images are infrared meibography images, and again you can see truncation, dilation. So we need to prevent this. Don't let it get this far. So how do we treat this? How do we prevent this? One thing is lubrication. So lubricating the eyes, especially with a lipid-containing artificial tear. In fact, a lot of our contact lens patients, we recommend putting a drop of that artificial tear in the bowl of the contact lens before they insert it on the eye. And you could possibly make a case for, even if an athlete has minimal refractive error, potentially wearing a contact lens just to protect the ocular surface and to maintain that lipid layer, that tear film layer over the ocular surface while they're performing. So not necessarily using it for its refractive properties, but using it for its surface properties. If you see blepharitis, especially young active people have very active sebaceous glands. So if there's a lot of blepharitis debris, certainly take care of that, clean it up. And then the next step is improve the meibomian gland function. Now how do we do that? We do that through warm compresses, physical expression in the office, blinking exercises, and then something that one of the later speakers is going to talk about, nutrition and supplements. So how do we improve the quality of the meibum? Just a quick note on blepharitis. I know that there's a lot of products out there, lash scrubs and wipes and all sorts of things. And if you have something that works for you or for your patient, that's great. One of the things that we like to use is just plain old off-the-shelf mineral oil. Acts as a great solvent for the dead epithelial cells and all the other surface debris, makeup, that sort of stuff. And also think about it compared to what it does if it gets in the tear film versus what a soap does. So if you have an oily dishpan sitting in your sink, you've just fried up some bacon or something. You can tell I'm hungry for lunch. And you put a drop of dish soap in it. What happens to that oily surface? It disperses. Same sort of thing here. If you're using soap or shampoo or cleansers around the eyes and you get a small amount in the tear film, it's going to disperse that oil layer. Warm compresses. When I was a student, not that long ago, I remember hearing about, oh, just tell your patient to do warm compresses. So if you tell a symptomatic patient to do warm compresses, the non-compliance is over 50%. If you tell an asymptomatic patient to do warm compresses, first of all, they're going to go, warm compresses. Second of all, even if they do them, you want to make sure that they're effective. So in order for the heat to actually affect the meibum and to reach the melting point and the therapeutic effect, the compresses need to be on for a period of at least 6 minutes. So I tell patients, do the warm compresses for 8 to 10 minutes, which is huge. The compliance goes way down. But when you look at the data and the temperature curves, this is why some people don't get any relief despite doing warm compresses every single day. Now, some people do, because the 6 minutes and the 40 degrees, that's a population average. So depending on the meibum changes that happen in each individual, the melting point may be higher or lower. Also depending on the thickness of the tissue, the heat having to travel through the periocular surface to get to the meibomian glands, that may be thicker or thinner. There's going to be differences in the anatomy. So this then comes down to the importance of blinking. Blinking not only spreads the tear film across the ocular surface, but it also stimulates secretion from the meibomian glands. So one of the ways that the meibomian glands are stimulated is when the upper lid meets the lower lid, and there's almost that little pressure between the two lid margins. That negative pressure expresses some of the material from the glands. However, recent work has also shown that there are extensions of the orbicularis muscle that wrap around those little individual meibomian glands to help squeeze the material out, kind of like squeezing a tube of toothpaste. So in order for this to work, in order for this system to function optimally, you need a complete blink, which this is something that I think could be a huge area looking at, especially in athletes, because in computer users, we know there's been lots of data looking at decreased blink rate when you're visually engaged in a task, and also an increased proportion of partial blinks. So upper lid comes down, covers the line of sight, the brain says, great, you blinked, it goes right back up. Well, that may be good for spreading the tear film around, redistribution, but it doesn't work for expressing the secretions from the meibomian glands themselves. So, seriously, blinking exercises can help. Now, I'm not sure that this is something that you want someone doing when they've got, a fastball coming at them or curveball. Those are baseball terms, right? But perhaps beforehand. And the other thing to think about is, in our elite athletes, they're not on the field 100% of the time. So what are they doing when they're not on the field? Are they staring at their iPad, portable DVD player, cell phone, sitting on an airplane, just staring at something? Think about what's going on there. So when I first started in practice with Dr. Korb, he said, okay, we teach our patients blinking exercises. And I thought, okay. Yes, he's been doing this for 40 years. And I thought to myself, okay, this is a new job. He's very established. I'm clearly,
Go with it.
I'm not. I'm just going to go with it. I said, okay, Dr. Korb, we teach our patients blinking exercises. Well, I'm glad I listened to him. I guess 50 years experience has some significant benefits because I've seen this make a dramatic difference in symptomatic patients, in computer users who come in complaining and they can't function. So if it makes such a difference in these patients, I think we could extend that to our athletes. So kind of putting this all together, poor blinking leads to MGD, decrease in the lipid layer leads to increased evaporation, ocular surface instability, visual compromise. Absolutely. I am so glad you asked. Blinking exercises are as simple as close, pause 1, 2, squeeze 1, 2, open. Simple as that. So the pause allows the upper and lower lid margins to come fully in contact with each other. And the squeeze activates the meibomian glands. And that's that. And a few repetitions of that. We recommend for our dry eye patients or our heavy computer users, we recommend doing a few repetitions, 5 to 10 repetitions once an hour. But the main thing is if you can link it to a task you do repetitively, for me, every time I sit down at a slit lamp, because if you're linking it to something you do repetitively, then it becomes a conditioned behavior, and you'll do it even when you're not thinking about it. So the main thing that I'm advocating here is prevention. So yes, we all know that dry eye starts this big cascade, inflammation, physiological changes, all these sorts of things. And maybe that's not at the top of your list when you're looking at elite athletes. But let's stop it before it can even start. So early diagnosis, educating people about this, being proactive in our treatment versus reactive, And then, so no one forgets what I said here, I've got this corny little illustration of the tooth. So we're all told from the time we're kids, brush and floss your teeth. Did you brush your teeth before you went to bed? Did you floss your teeth? Well, what happens if you don't brush and floss your teeth? Well, you get bad breath, and I might not have very many friends. But my teeth are going to be okay for a little while. You'll be okay. Until 6 months later, a year later, 2 years later, you get gum disease. But we don't let, or dentistry doesn't let it get that far. They tell you, okay, prevent that by brushing your teeth daily. I'm going to take a big risk and say in another 30 years, we'll teach our kids who are now glued to electronic devices all the time, we will teach them blinking exercises the same way that we teach them to brush and floss their teeth. So one of the things that we've talked about here, all of this is based on dry eye practice, dry eye management. But as our other speakers have pointed out, how does this correlate to sports performance? And if we train this, do we get results? Not just in do their blink rates improve or do their speed questionnaires improve, their OSDI questionnaires improve. Does that translate
to performance?
To performance.
Yeah.
And that's a challenge that I have for everybody else in this room, because I think it's an area that we need to look at more going forward. So I just want to say thank you so much for letting me be here. This is a lot of fun.
It was great. Yeah.
And we'd like to open it up to questions.
Are you aware of any athletes that have come in, professional or non, for like a preseason LipiFlow treatment?
The question was, am I aware of any athletes that have come in for a preseason LipiFlow treatment? A LipiFlow treatment, for those of you that may or may not be familiar with it, is a 12-minute in-office procedure that combines heat and massage to evacuate the contents of the meibomian glands. I personally haven't seen any athletes that have come in for a preseason treatment. I think that that could be
I haven't
a good
either,
potential.
but I can make a case that, you know, if they have compromised tear quality and lipid quality, that maybe would help them, you know, and that's, again, something for food for thought in the future is research on blink rates and how it affects performance.
Great
What's interesting is the more longer-term effect, especially those guys going to Arizona, for example, in very dry conditions.
Mm-hmm.
How do they damage their meibomian glands? And they don't need the treatment; they need prevention to prevent damage.
Right, right.
Yeah. Yep.
Have you ever had patients, I don't know if you've seen a lot of patients from colleges where they have a lot of demand looking at computers, looking at the screen for class and all that, and then the players that play better on the field or on the ice or whatever compared to the ones that aren't performing as well, how their tear film?
Yeah, so I'll speak to the question was about performance and tear film in especially college athletes, because they spend so much time studying and on devices, and how that relates to performance based on tear film. And you know, certainly in terms of college students, I'm seeing practicing in downtown Boston, we have access to a lot of college students. There's a lot of universities and colleges in a very small geographical area. And I certainly am seeing more and more severe dry eye, actually debilitating dry eye conditions
In young people.
in
yeah.
young people
Yeah.
because of the demand of staring at a visual screen. Alan, I don't know if you've had
Yeah, I
experience
mean,
with some
I see the
athletes
same
with
thing.
that.
I mean, in 30 years of practice, it's changed from early in my career, they were taught in optometry school, the only people that have ocular surface disease are menopausal women. And you see that in young males, and they're 15, that just don't eat properly. I think nutrition is huge. They don't eat properly. In college, alcohol is a big thing, and that probably dehydrates them. They don't drink enough water. And I'm seeing, you know, 19, 20-year-olds consistently in my practice with dry eyes. I never saw that 30 years ago. So
And
I think there's a lot to be said for prevention, as we talked about, you know, talking to patients when they're young and putting them, we're all putting them in greater and better contact materials, but are they really taking care of their lids, and are they using the re-wetting drops during the day? Are they blinking? And some of the people, we all see them, they're obsessed with their phone, or when they're not at work, they're on their phone, they're on the tablet. I mean, it's you're talking about 15-hour days that are just looking at a digital device. They don't go outside. You know, I think there's been studies on people that just go outside and play sports. You know, what the benefits to them.
Yeah. So I guess in answer to your question, no, I haven't seen it specifically in the performance of collegiate athletes, but certainly in the college-age population. Yes.
You mentioned earlier that when you fail to blink for more than 3 seconds, contrast sensitivity is reduced. Do you know what the percentage of that is?
Yeah, so the question was about reduction of contrast sensitivity in when you haven't blinked for 3 seconds. So I'll let Alan talk about that
I
because
don't
he
think
found
it
a
really
great article.
raised percentage, but it did note in a couple of the studies that the tear film it correlates with the tear film breakdown, and you get more reduction in contrast sensitivity. You get high order aberrations after the 3 second mark. And I don't know what the average blink rate in an athlete is, but I guess it depends on what sport they're performing. But I could certainly think that you can correlate with a computer user. The average blink rate in some computer users is as little as every 5-6 seconds. So if you're breaking down after 3, you got that 2 or 3 seconds that the degradation of the tear film. It could certainly extend to performance, quality of the image, especially in quick saccadic eye movements in baseball and hockey. I mean, it'd be an interesting thing to study. But I think if you could maybe train those people to blink properly, as we talked about, or maybe increase tear film, just normal lipid tears production, and just do it every few hours and learn to blink, close your eyes. Maybe it will help them in sports performance. It'd be an interesting topic to study.
So the study that Alan had referenced at the beginning didn't look specifically at contrast sensitivity function, but it did look at the number of higher order aberrations. Right. And after that 3 second interval, the higher order aberrations increased by 1.44 times, so almost 1.5 times the number of higher order aberrations, which then you can extrapolate to contrast sensitivity, function, and performance.
Mm-hmm.
Yes?
Do you find that the blinking exercises improve incomplete blink at all?
Absolutely. So the question was about blinking exercises and incomplete blinks or partial blinks versus complete blinks. And yes, I've seen that blinking exercises make a huge difference in that. So the lag ophthalmos at night, or if they have an incomplete lid seal at night, blinking exercises can have some effect to that, but the main way to manage that, even if it's very mild lag ophthalmos, or even if it's not true lag ophthalmos space between the two lids, but it's incomplete seal, looking at the light test and seeing light come out so air can get in. The main way to take care of that is with ointment or a mask at night to prevent that evaporative stress for the 6, 8, 10, 12 hours you're asleep, so that you're not fighting an uphill battle from the moment you wake up. Great question. Yes?
Do you diagnostically use any of the tear osmolarity units or anything in your offices? And if so,
So the question was, do we use any of the tear osmolarity instruments in our offices? And I will say I do not.
I haven't, but I've been certainly on the fence to look at it. I think there's a lot to be said for it. I remember going to a conference myself, and I have very dry eyes, and my left eye is much worse than my right, and it's typical on days I don't wear my contacts, and the number in my one eye was much worse than the other eye. So it did correlate for me, but if you look at the literature and people that have them, they get different, sometimes false positives, false negatives, but I think what they all say is it gives you a number or reference number that you can go back and study and say, hey, it was 350, now it went down to 250, we improved it. And I think you could say it probably correlates with symptoms, improvement in symptoms.
Yeah, and in our office we're trying to intervene prior to changes in osmolarity, so before we get that far down in the inflammatory cascade. So that's one of the reasons why we are doing a bunch of other stuff, and it's just one more test. It certainly, if people are using it, it does provide a great metric, and again, metrics are key in changing the culture.
People like to hear a number. They want to know a number.
Numbers are helpful.
Yeah.
Yes?
Any information or guidance for contact lens wearing relative to lens care, so the chemical care systems, obviously, versus peroxide versus
Yeah.
single-use product.
So the question was about recommendations for lens care in contact lens wearers, what chemicals to use versus peroxide. Alan, if you want to. give
I
your
think
opinion.
all things being equal, we don't want them to introduce any chemicals, which lends itself to dailies. But if, in fact, it's a patient that can't wear a daily or doesn't want to wear a daily, I think the peroxide systems definitely show a lot of promise. I've put patients from all-purpose solutions to peroxide, and they've come back and a big improvement in their symptoms. So clearly there's a benefit there. No preservatives. I think the disinfection cycle, peroxide definitely gets off bacteria and just protein. It just kind of gets it off, and I think all of us that have used it see a difference, definitely.
And then sorry, just to follow up to that, the peroxide systems don't typically have a conditioner built into the solution.
Correct.
Whereas some of the all-purpose solutions tend that there's a conditioner that.
But I'll have them put a lipid drop on the lens, as we talked about. I mean, just any kind of lipid drop. It doesn't have to be approved for contact lens wear. Just put it on the lens, especially on a lens that's been worn for a month or so. It really helps performance. It helps them comfort. And if they have symptoms during the day, have them take it out midday, let it soak in solution, just a re-wetting drop, or just saline in for about an hour and put it back in. And I touched upon that and maybe in athletes is maybe in between innings if they have a dry eye or have discomfort is take their lenses out, soak them, and put a new pair in.
Sorry, let me just throw out there that was an off-label recommendation,
Right,
and
yeah,
we're
yeah.
just
It's not-
saying what we do in our practice, and
Not FDA approved.
everyone can make their own decision on that. Yes.
If someone's wearing contacts and they're in a sport where they want to try to enhance, that tear condition, can they do those lid exercises with the contact in? Would that be a benefit?
So the question was, can you do the blinking exercises with contacts in? And the answer is absolutely.
Extends to anybody.
Yeah,
Yeah.
because one of the things that we know contact lens wear does is it decreases the corneal sensitivity. So you're taking away part of your feedback loop there to the blink cycle. So actually doing it with the contact in, again, just conditions the muscle in the blink there.